Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Ravindra BS, gastroenterologist at Fortis Hospital, Bengaluru, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective, evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
I am Dr. Ravindra BS, Director, Gastroenterology and Hepatology, Fortis Hospital, Bannerghatta Road, Bangalore, and Meenakshi Institute of Gastroenterology, Bannerghatta Road, Bangalore.
So, doctor, question for you is, once IBS is diagnosed, what is your first-line approach to management?
See, once the IBS is diagnosed, first thing is we'll tell the patient, assure that this is not a disease which will harm him. And then second important thing is we always tell them that diet, exercise, sleep, they have to be maintained. That is a part of the treatment, and medicine is a part of the treatment. I think this is the first thing. Once I diagnose IBS, I will counsel the patients about this.
How do you tailor treatment between IBS-D, IBS-C, and mixed IBS?
See, IBS diarrhea, once it is diagnosed, we presume that we have done blood investigations, stool calprotectin, and colonoscopy, everything normal. Then IBS-D, we treat with rifaximin for 2 weeks. And then in some cases, if there is a suspicion of associated SIBO, then we can add on probiotic. That is the thing what we do. If patient has got abdominal pain, then we use mebaverin, or the pain antispasmodics, we use this. So that for IBS-D, this is the treatment. Coming to the IBS constipation, the constipation part is being treated by PEG, and then the pain part is treated by antispasmodics. We have pinavarium, we have mebaverin. These are the two common drugs we use for IBS constipation. Suppose IBS mixed, if it is there, when they have a diarrhea type, we treat with rifaximin. When they have a constipation type, we treat with PEG, and along with pain medications, they have the antispasmodic.
What's your opinion on the role of rifaximin in IBS-D? Where does it fit best?
I think IBS diarrhea, it is now very, very clear. We have to use rifaximin. This is a primary drug we use in IBS diarrhea treatment, because as we all know, most of this IBS diarrhea, they have gut dysbiosis. That's why rifaximin is a major molecule we use in IBS diarrhea type. Especially, we will also know these patients have bloating, flatulence, and then Bristol scale, usually it will be 5, 6, and 7. If this is there, then rifaximin is the first line choice, because basically this will work on the IBS diarrhea type.
How do you decide when to repeat a course of rifaximin or switch to another therapy?
Usually, the course of action is we give rifaximin for 2 weeks and then follow them after a month. And if symptoms are well, then we stop everything. But usually what I do is at least 8 to 12 weeks. If symptoms are repeatedly coming, I tell them 12 weeks is the time, 8 to 12 weeks. Most of the time it is 12 weeks, I will repeat rifaximin. Suppose the second course of rifaximin doesn't work. In that scenario, you have metronidazole, you have amoxicillin clavulanic acid. These are the drugs we use in failure of rifaximin. But I think most of the time, rifaximin always works. That's why rifaximin is the workhorse for IBS diarrhea type of diseases.
How important is patient counseling in IBS management? What key messages do you give?
See, most important thing in IBS diarrhea or IBS constipation is we have to counsel. That is the key word here. Because the problem is, unlike you have a infection, or you have a problem like malaria or a typhoid or a dengue, you have a definitive treatment. Whereas irritable bowel syndrome, we all know, is a conglomeration of problems where you have gut dysbiosis, visceral hypersensitivity, and then stress and anxiety also. That's why I always tell them in this particular case, patient also has to involve effectively in the management, because sleep has to be good, timely food consumption is very, very important. And then stress and anxiety has to be managed. And then as a physician's role or a gastroenterologist's role is to give medications to reduce the gut dysbiosis. That's why the key message for IBS is we have to spend time with the patients, tell that this is a disease which doesn't harm him. And then main thing is diet counseling is very important. And then exercises, we have to tell them that proper exercises they have to do every day. And then stress, anxiety we need to address. And then medication is a part of the treatment. I tell it's a circle. One third is by the physician. One third, actually two third of the thing, the patient has to work in that direction so that he has an effective treatment for irritable bowel syndrome.
What's the role of diet? Do you recommend low FODMAP, fiber modification, or any particular dietary pattern?
I think diet is a very important factor in the management of irritable bowel syndrome. Of course, we always tell low food map is one thing, but low food map is not the panacea because we all know that in Indian subcontinent, some of these things we cannot completely avoid. That's why I tell them this is a rough guide you have to use. These are the high food map things. If you find these giving problem, those things you have to avoid. Then excessive fibers better to avoid because lot of bloating can happen. This is what I tell. And then we have to modify the diet always in conjunction with the locality because in northern India the way we eat is different, southern India the way is different. That's why this has to be in conjunction with the locality of the what the food consumption they do. That's why we have to sit with them what they are having food, those things we need to assess, and then this low food map has to be used in them.
Do probiotics or prebiotics have a role in IBS treatment?
Data are conflicting. Some data says that there is a definitive use. Some data they say that there is not much of a use of pro and prebiotics. But in patients who have already used a lot of antibiotics, probiotics and prebiotics definitely have got a role because they help in making the gut dysbiosis better. I think that's the thing. And now we also have stool analysis. Most of the centers, patients themselves, they are doing this gut microbiome analysis. And then I think there is some progress which is happening in this area where there is a gut microbiome analysis in the stool. And based on that, probiotics are being tried. I think this area is one area is always in some progressive things are happening in this area. At this point of time, yes, pro and probiotics. In certain cases, we definitely use in IBS, especially the diarrhea type.
How do you deal with recurrent or relapsing IBS cases that come back after initial improvement?
See, IBS, I always tell them that there is always a recurrence because I always counsel the patient. The problem is not like malaria, you give treatment for malaria, it will completely go away. Because irritable bowel syndrome is nothing but it's a conglomeration of many things which are going on in this disease. Basically, if there is a sleep disturbance, anxiety, depression, patient's dietary changes happen, travel, and then gut dysbiosis, all of them, they will be playing a role in IBS. That's why I always tell, once I see IBS, two things I will always tell them. See, don't think that you see a doctor, take one medicine, it will completely go away. That's why IBS, we always tell them that it is recurring. If there is a recurrence, I always tell where they have gone wrong. If they have gone wrong in the diet, we need to sort out that. If they have stress, anxiety, sleep disorder, that we need to address. If they have a gut dysbiosis, with that we have to address with medications. But the bottom line is irritable bowel syndrome can always recur if there is a problem in all these areas where I mentioned now.
How do you balance pharmacologic and non-pharmacologic management approaches in IBS?
See, always in irritable bowel syndrome, both pharmacology and non-pharmacology are key. I always tell my patients, medicines work in only one third. Two third of the things are done by two things. One is diet, second one is sleep, third one is exercise, fourth one is they should always have, if there is any anxiety, stress disorder, depression, that has to be treated. That's why pharmacology constitutes maybe one third to half, non-pharmacology constitutes two-thirds to half. I think this is how the management of both pharmacology and non-pharmacological methods have to be used in irritable bowel syndrome.
The most common mistake you see in IBS management?
I think the most common mistake people do in IBS management is the diagnosis itself. See, many a time we see everybody who has come, who has been not been evaluated, just telling that they have an irritable bowel syndrome. Chest patient comes with abdominal pain, diarrhea. They give a course of antibiotics and then they say they have irritable bowel syndrome. I think the commonest mistake is not proper diagnosis of the irritable bowel syndrome is the commonest mistake. People have an organic disease like celiac disease. People have an organic disease like Crohn's disease. People have an organic disease like tuberculosis, and they are being treated as irritable bowel syndrome. I think that's the common mistake we see in the management of irritable bowel syndrome. This is a common thing most gastroenterologists we see.
One word that describes a typical IBS patient journey?
I think it's a one word I mean to say is most of the time it is frustration what they undergo. This is a single one word I can say how irritable bowel syndrome is a frustration. That's what they always went to the physician, family, and the gastroenterologist.
What's your gut-friendly morning habit?
I think the most important thing is you start your day with liter of warm water every day in the morning. After that, you go to have a gym or a morning walk. We should make this very important habit. First thing in the morning, drink 1 liter of warm water, and then diet and exercise is the one thing which I will always tell them. Don't gulp coffee or tea in the morning immediately once you get up, and don't get into the habit of seeing your mobile in the morning the moment you get up. Get up, have a positive mind in the morning, just spend 1 or 2 minutes that you are well, and then have a liter of water, do some form of exercise. I think that's the key thing in the management of irritable bowel syndrome, and a positive approach a patient should have. Should always affirm that he's well, and then the water and the exercise that they should do. I think that's the key thing in the management of irritable bowel syndrome. I will always tell my patients. And I also thank everybody. We had a wonderful session of this rapid fire IBS management. Thank you very much.
Thank you, Doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.